So Joe, I, I was saddened to realize that our conversation in 2017 was not recorded. I can't even find my notes for the questions I asked you, but so I have to rely on my kind of scrappy memory. But as I recall, in 2017, we were talking about, oh, maybe it would be important to develop the tools to be able to test for dangerous new viruses that might be really bad for the world. And we were very much talking in the future tense at the time. We had Ebola to talk about, and some other, in hindsight, relatively small outbreaks. But it's kind of eerie to think back on that conversation because, we were talking about COVID-19. We just didn't know it. I mean, I don't know what it's like for you to think about that before time.
I mean, it was terribly ironic, actually. I think, part of our conversation, as I remember it, and 2017 was around the time that we were formulating these plans, was around this idea that maybe we need a monitoring network that would be able to detect new and emerging pathogens in people and other species. And that one of the things that I had wanted to do and actually partially did to some extent, we're still doing it at the Chan Zuckerberg Biohub, which is this nonprofit research institute. I think you asked, what new things are you doing at this institute around this idea? Is to try and build a worldwide monitoring network, based mainly in low and middle income countries that suffer the majority of the burden of infectious disease in the world. Not so much anymore with COVID, but certainly most of the time. And that these sensor nodes, if you will, would work on local problems in each of those countries, but they would aggregate that data centrally into the cloud where, it could be processed and kind of observed real time globally. Like, some other people have called it like the weather map. I think George Church uses that. Other people have used monitoring network, but it's certainly a network of surveillance nodes that would be able to sense when something's new in our environment. Right. And I still believe that we need that. And it was sort of ironic that we were talking about that and that we got kind of the way through that project when COVID hit.
Well, let's talk about when COVID hit. I mean, I'm sure all of us will remember for the rest of our lives what that was like in early 2020 as this sort of tidal wave hit us. But I mean, for you as a scientist who is studying viruses and was very much involved in like how to use these methods of sequencing their genes to track them and to figure out what they're doing beyond just looking at symptoms and people dying. I mean, what was it like for you in early 2020?
Wow. Yeah, great question. Early 2020 was kind of crazy. So in the very beginning of 2020, from January 1st to around the 10th, I was actually in Phnom Penh, Cambodia. And we'd gone there to set up one of these, sensor nodes with our colleagues there in Cambodia, who together in a partnership with the Bill and Melinda Gates Foundation and Chan Zuckerberg Initiative, we're going to set up one of these sites that would be sequencing children, mainly children with unknown fevers, looking mainly at mosquito-borne disease, maybe like dengue and things like that. Well, that was the intent. And we had set up this sequencing and it was really working well. And actually coming back through China in the airport on the way back home, like January 10th, the difference between January 1st and 10th, there was a lot more security and a different feel in the airport, like very different, with these acrylic boxes that you stand in and monitor fevers. And I kind of wondered to myself, man, what's going on? This isn't good. And now, ironically, even more ironically, like after we got back, just a couple weeks after we got back, that operation in Cambodia, in Phnom Penh, detected, actually worked to actually sequence one of the full-length genomes of one of the first Chinese tourists outside of China into Cambodia with COVID in mid-January.
And they, I mean, if you if you had scheduled your visit for like a month later, they wouldn't have that ready to go.
Yeah, exactly. It was just in the nick of time for them to do the work that they did,
Mhm.
like really right before it. And if I'd been there a month later, I probably wouldn't have come home either, like
True.
stuck there. Um, they did a great job, and so it's one of the earliest non-Chinese sequences of COVID, actually, not
Mhm.
sequenced in China. And so the network actually performed kind of just like it should. And actually, COVID wasn't even in the database yet. So when the sample was run, it was identified as, bat-like, SARS-like coronavirus. Like, oh, okay. So even though, it showed that it could detect, although the COVID sequence was known at the time that it was done at that point, the database wasn't updated. So it's as if you did the experiment not knowing what COVID was, and it functioned perfectly. So that was all, that was gratifying, and we're sort of a little bit in pat on the back mode. But what we didn't realize was what was coming. And for me personally, I had worked on SARS in 2003. And this, I thought, might be like that. I really thought that this is going to be a replay of SARS 2003, meaning everyone who gets sick is going to be symptomatic and they'll not spread the virus before they're symptomatic. It'll be easy to quarantine. A bunch of people are going to get sick, but they'll be quarantinable, and we'll limit the spread of this thing. That's what I thought. That was by late January. Now, by February, a lot of disturbing data coming out, including the Diamond Princess, episode. And then in March,
that's you got that cruise ship where a lot of people were just not showing symptoms.
That's right, exactly. And so this idea that you could have people infected and transmitting virus but not be symptomatic, that's a deal breaker for everything that we know about how to handle a pandemic, because it means that you're going to have people walking around that, I feel fine. Why shouldn't I go to work? But they're transmitting virus.
Mm-hmm.
So it makes it incredibly difficult to control. Now, a bunch of stuff happened in February and into March, and we ended up spinning up clinical testing, and we could talk about that more. But right after, we got testing going in California and the Bay Area, we really did a deep dive in our local neighborhoods in San Francisco and confirmed for ourselves that 50% of the people that we tested had no symptoms, yet had levels of virus that were just the same as people in the ICU. And that's kind of, that point, that was the point where you really feel like the ground drop away from below you. It's kind of a little bit of a panicky moment, because how are you going to keep a lid on something like that? Like, no hope of control at that point,
Right.
Without a vaccine.
Right. Yeah. So, I mean, vaccines were 9 months to a year away at that point. So how did you, yeah, I mean, maybe you could talk a little bit more. I mean, in advance of a vaccine, like how, instead of like setting up some network around the world, you are very busy right at home. So what was your strategy over that, 9 months to a year in California? How did you use your tools for sequencing and tracking viruses for that?
Yeah, a great question. So, when we got to late February, early March, we knew, first of all, vaccine was going to be some ways off. We didn't know when. We knew that it's going to be hard to control. And we also were, kind of presented with the facts right in our face that testing in California and in much of the rest of the United States wasn't going so hot. Like, you probably reported on this plenty, Carl. You remember, like, when tests would take 14 days or something, and you're already recovered by 14 days most of the time. It has no point and no value, and we needed tests in 24 hours or less, minutes if we could. And so we made the decision early on that we had to get into that game of actually delivering clinical tests, which is we'd never planned to do. We're going to have to focus on California and protect people in our own backyard, especially skilled nursing facilities, prisons, jails, safety net clinics, and some of the most vulnerable populations in our communities, as well as realizing that the evenness of the virus, it wasn't distributed evenly across our communities. there were certain communities, and in San Francisco, Latino, Hispanic, Latinx populations that were really shouldering a heavy burden, like way more than other parts of the city. And we had to get testing to them too. So that was a game changer for us. But luckily, with the support of Chan Zuckerberg initiative, and because the BioHub's a flexible place, we could kind of tell everybody, whatever you were working on yesterday, drop it. It's done. You're working on COVID. Everybody's working on COVID. I don't care what you're working on before. You're working on COVID now. And we spun up a testing facility that we actually built in like 8 days, like from start to finish, to first clinical test return to a patient, 8 days. So it's very gratifying, but everybody was working around the clock. And at one point we had maybe 175 people in total working on it, just in our little institute. So kind of intense.
I mean, did you expect that it would take so much work to get rapid testing in the United States?
Oh, I didn't appreciate it. I'll be honest. And I did not know a lot about how public health systems work in the United States, let alone in my own backyard in California. And so, I've been focused on like, let's do this thing in Cambodia. I don't even know how diagnostic testing would work between Humboldt County and San Francisco. So it's kind of embarrassing. I learned a lot. I learned a lot really fast. And what I learned was not good. The county system of health jurisdictions, which is very common across the United States, and certainly that's the one we have here in California, is great for hyper-local problems. It is not great for a pandemic that doesn't care about your county borders. Mm-hmm. So having different health jurisdictions with different systems and different resources and laboratory capabilities, it's a patchwork system that is uniquely unprepared for what is a pandemic. Mm-hmm. I learned that first and foremost. And we learned this kind of in very stark and horrific ways. And I've told this story, many times, but it's a great anecdote, about counties that couldn't receive health results except by fax.
I've heard this from other people. Yeah, that they have to have it's a common thing that the fax machine is alive and well at these public health systems.
Well, you got to admit, sitting near Silicon Valley, that's kind of embarrassing. And fax machines are notoriously, error prone and break all the time and don't transmit. And I'll tell you one small add-on to this. I've told others, and forgive me if I'm repeating myself, but with one batch of results that went to one county, we got kind of an angry call the next day saying, "Hey, why didn't you send like the other half of the results? We only got half." And we figured out that it was their 1992 fax machine only had a 40-page buffer, so it couldn't take more than 40 pages. And then it just quit without an error. And it's, here we are, using high-tech robots and all kinds of cool things to do COVID testing, and we're reduced to using an ancient technology with like a wax thermal transfer drum. This is really just ridiculous. I asked, why do you guys just buy a modern fax machine? I don't know if there is a modern fax machine, but maybe. And the answer was, well, it wasn't in, it's not in our budget. We don't have the budget for that. And that just really brought home this feeling that a lot of these departments of public health who are doing heroic work under horrible circumstances are operating in an environment of kind of near poverty.
And have been for years or decades. Yeah. Do you feel like the situation has gotten any better in the past year and a half? I mean, are public health systems able to, work on in a faster way with this kind of data yet?
It's not there yet. I definitely see signs of improvement. And, there's now a lot of federal dollars that are flowing into state health systems that are then coming down to county health systems. And
a lot.
One would hope, right,
that $2 billion. Yeah, like you would hope that would make a difference.
You would hope that would make a difference. And I am seeing some signs of that, of being modernizing the information networks to be able to transmit things faster, better, cheaper without a fax machine and so on. So that I do see some progress there, but I wouldn't say that, suddenly we're okay, like we're pandemic ready. A lot of the systemic problems are still there. They're structural problems that need to be rebuilt from the ground up. And that's going to take time, not just the dollars. And personnel. And we have to have champions who want to go back into public health and get in there. We lost a lot of public health champions during the pandemic, not because they got sick or anything, but because they quit, because it was terrible working conditions. I think we need a new era where we can actually recruit really great people into these professions. And we also have to create, I would like to see, at least for the next pandemic, some sort of volunteer corps or some sort of university research network that would be able to turn on a dime and dedicate its resources towards public health in an emergency. It was very piecemeal, very patchwork, very uneven.
I mean, did you see any? We're painting a pretty dire picture here. I mean, do you see any success stories in California where public health combined with these new methods like of gene sequencing actually really made a difference, really saved lives?
Yes. So one of the things that we are very enthusiastic about early on in the pandemic, starting around April 2020, was getting this idea of genomic epidemiology into the hands of public health officials. And that what genomic epidemiology really means is, okay, not just sequencing viruses to say that's a variant, this is a variant, but actually connecting the dots. Which infection is more similar to each other? In a factory, if a couple people got sick, let's say 3 or 4 people get sick, did they get it from each other? Or did they coincidentally bring it in independently? And the difference matters, because if they got it from each other on the job, it would suggest health and safety controls in that workplace were not adequate. So the genomic epidemiology can actually shed light on that very easily. Like, wait a second, all these are related. They had to have got it from each other. Whereas conversely, like if they're very different versions of the COVID, every version of COVID is like a breadcrumb trail. It would suggest very strongly, almost concretely, they couldn't have got it from each other. Mm-hmm. And that actually can empower health officials to make decisions about the workplace, about what things get closed and open, about schools, all kinds of stuff. And so we were actually pushing this data into the state officials' hands, but also now training our partners in public health to not only use the data, but generate it themselves. And I've seen a lot of progress in that, because it is an incredibly powerful tool.
So this was all going on before the variants. And I remember I gave you a call a few months ago, as variants were starting to become a problem. We had, there was Alpha, formerly known as B117, and then there was also what was called the California variant, which now is Iota.
Yeah.
And Iota, I remember talking to you and you're like, well, like it's moderately more transmissible, you were finding, but, you sort of had a wait and see attitude about it. And I mean, not to put too fine a spin on it, but like Alpha really kicked Iota's ass. And so Iota is not really around much, but then came Delta. And Delta is now the big gorilla in the room, across the United States. And, even as we're getting vaccines out, Delta is on the march. So I'm sort of curious. I mean, and it seems like it's, it's driving some serious problems in California, for example. I'm just curious what your take is on Delta. Like, is this just another variant, or is this a variant that's got you very worried, or somewhere in between? Like, what does Delta mean to you?
Yeah, it's definitely concerning, and I'll tell you why. If you look at all previous variants, like what is now Alpha, B117, and things like this, they have very characteristic mutations. California had a mutation that was called, it was at position 452. B117 had one at 501, and there's a bunch of others. Okay. What we see in the Delta is like your worst mixtape of all those. It's not that it's something new, like, hey, here's a bunch of new mutations you've never seen before. Yeah, there's a couple new things there, but what is really concerning is it's got the best of the B117, it's got the best of the California variant, it's got a best of a bunch of things, all, P2, P1, whatever they're called now, all into one. And so it's actually the combination of a bunch of things that independently arose, now featured in kind of a single variant. So it's the bad mixtape version of previous variants. And we know each of those on their own had some effect. When you put them together, it seems to be even more aggressive. So that's why it's got me concerned. What is left? What else is on Mother Nature's trick box here that we haven't seen yet? And what else can go on top of Delta? I'm wondering, evolutionarily, will the virus run out of evolutionary runway? Or is it really truly infinite in terms of how far it can push it? Can't be infinite, it still has to interact with the receptor. So there's going to be some constraints somewhere, but I don't know that we've seen the end of the road. Which means, what does it mean? It means that, probably going to need a vaccine booster. I know there's a lot of speculation on that. I'm kind of if I was a betting person, I would say probably going to need one. And I think that that vaccine booster would probably need to be multivalent, meaning featuring kind of the greatest hits of variants, not the stuff that was here a year ago. And I think that we need to get to the point where we're, vaccinating children, under 12. Right now, it's 12 and up or whatever. That is not okay. It's, if the safety data is there, and I know that a lot of that data has been submitted. If the safety data is there, we got to act on it because school's going to start. And the fact that in areas that have high vaccination, like San Francisco, where we're over 80%. It's really pushing, what it's effectively doing is pushing the virus population into that unvaccinated reservoir, kids. And we're about to go back to school. And if all the infections are now going the way of Delta, and we know that the vaccine isn't perfect against Delta, it's still good, don't get me wrong, but it's still not, not perfect. And that every person has, a different immune response. We're going to see more breakthroughs. I think that's inevitable unless we get on top of this thing and we get on it quick.
What's your view on, you mentioned with kids, there's a huge amount of debate or controversy over, what COVID means for children. Do you look at, is your concern here that children can be a vector to older people who might be at greater risk for severe disease? Do you see it as a public health problem for the children themselves? What's your view on all this?
Yeah, so it's true that COVID disease in children appears more mild. No question. There's a lot of data to support that, even though they have high levels of virus. We did that study too. They have just as much virus as an adult. Good news is they're not super spreaders necessarily, but now that was with variants from 6 months ago, a year ago. What is it going to look like in kids now with these newer versions of the virus? I think we're going to have a hard time predicting that until we see it. I would hope that disease remains mild in kids. So to your point, yeah, the risk still is to, not kids, adults who are vaccinated, and more chances for breakthrough. And the fact that you have an unvaccinated pool of people that acts as a reservoir. And in that reservoir, the virus is, doing its thing, mutating on its regular clock, which means more shots on goal for something we don't want to see.
So, Delta is, like all these variants, Delta is moving very fast. It's already the dominant variant. It only took, a few weeks for it to reach that. The process of regulation and authorization of vaccines, it's a slow and stately process, comparatively speaking. Even if the FDA hustles as fast as it can, I wouldn't expect vaccines for kids under 12 for weeks to come, maybe months.
Yeah, and I don't have much insight into, the speed at which FDA does this process. But what I will say to that, and what I hope would lend to a faster authorization, is that these are mRNA vaccines, at least the Moderna and Pfizer type are. And what's nice about that is the vehicle you deliver it in, the formulation, all that's the same. The only thing you're changing is the sequence of the bases in the RNA. So it should be programmable. You should be able to program in multiple variants without actually changing a lot in the rest of the vaccine. And so I would hope that the safety data we've seen before would carry forward to new authorizations, because you're not really changing the chemistry of the situation. It's still got all, the same four bases. They're just in different order.
Do you think that we should be getting sort of these variant type boosters, like, as soon as possible, like right now, or should we wait till the fall, or what do you think?
I mean, it depends on where in the country you're talking about vaccine rates. We're seeing upticks in certain parts that are worrisome, I would say now. Other places like the Bay Area, pretty low rates, great vaccination, people still wearing masks. And so maybe that's a fall thing, but it's really going to depend on how fast things take off. I would like to have it on hand.
In the meantime, I mean, there are sort of public health measures that are being put in place. So what do you think about, so to the south of you in California, LA apparently is getting a lot stricter about requiring masks, even if you're vaccinated. Do you think that that's going to be helpful?
I think mask wearing is just it's a great way to prevent disease. It works. And it's a simple, cheap thing. I think that if we're seeing significant uptick in numbers, then I fully support mask wearing, because it's simple, it's cheap, it's not invasive. I mean, it's just an easy thing to do. I get it. It's uncomfortable. It makes your mouth hot, whatever, but it's a small price to pay for avoiding what could be, a really bad outcome. So if we're seeing upticks in these places, I do support additional measures to roll back to mask wearing and also sporting events and things like this. We know how disease is spread. It's not a mystery. We know how to block it too. But those social controls aren't very popular. And I understand why. It's not fun to not be able to go to your favorite sporting event, but this is real, and it's real people's lives we're dealing with.
So just kind of looking forward, I mean, it's kind of hard to look forward from the middle of a pandemic, where we've got these surges of Delta here in the United States, and in other, Africa and other places have it way worse now. But I'm just sort of wondering, looking forward, your concept that you had, that you were working on right before the pandemic, of a sort of an international network of these sort of sentinel systems, has the pandemic sort of changed your thinking about it in any way, or I mean, how would you, when you look forward to how this might work for even more viruses, what are your thoughts now, in July 2021?
Yeah, more conviction than ever. I think what it taught me was like, dang, I wish we'd done this like 10 years ago, not just 5 years ago. I wish we had gone farther and harder before this happened. And I also think that this isn't the last time we're going to see something like this. Maybe this is once in 100 years, just like the 1918 flu, but I don't necessarily think so, given our population density and other factors that are different. And it's not just about COVID too. It's flu, it's drug-resistant bacteria, drug-resistant fungal species like Candida auris, mosquito-borne illness with global, with climate change. We're seeing mosquito illness, spread to areas that weren't there before. So all those things could benefit from a transparent, real-time, molecular-based, sentinel system, as you called it. That would be a fantastic a tool that the world should have. Just like we have high-tech ways of observing the weather, and other people have called it a weather map, we should have that weather map for pathogens.
Okay, but in California, a, a state in the, so California is a state in the wealthiest country in the world. It is, California itself has a GDP that, is, what is it like? If it was a country, I forget.
Seventh or eighth in the world.
Seventh or eighth in the world. And you were dealing with public health systems who were using fax machines.
Yeah.
So how is this idea of doing this across the world anything but a fantasy?
Yeah. So you're right. We need to fix the fax machine problem, right? Could we get rid of fax machines? Like, that would be a major victory.
Okay, step one. Yeah.
Do you have a fax machine, Carl?
I think my printer can work as a fax machine.
Okay, all right, right. Like, who has one of those? The people who own them are public health officials.
Yeah, they're keeping the companies in business, I guess.
So you're absolutely right that there needs to be some domestic restructuring, and I think that we can get to a place where that technology is working not just around the world, but in our own backyard. So you can't just do one job or the other. You have to do both. You have to pay attention to your own backyard, that was the wake up call for me.
Well, I guess my question is that if it's so challenging, even in California, how realistic is it to expect to set up a cutting edge, your dream of a system? How realistic will it be to set that up in Suriname, in Liberia, all over the world? Because viruses can come up anywhere. How is this really going to work?
Yeah. So tough. It's going to be a challenge for all the reasons you just described. However, I'd say there's a couple of things working in our favor, right? We're not, part of the problems that we describe for our public health systems here in California and other places, those are structural problems. We know what the answers are, and there's cheap answers to it, but they're structural problems that are, politically ingrained and, enshrined in legislation. I think the fax machine is actually mentioned in a piece of legislation. And so there has to be certain, so those kind of structural things we need to do better.
We need a new fax law. I agree. Okay.
Yeah, right. And in some ways, us spinning up one of these sentinel nodes in Cambodia with this high technology stuff was almost easier than making changes in the county next door. And, wow. and the beauty is the price of that kind of technology, the sequencing technology I'm describing, keeps falling in price drastically. Even over the last 10 years, it's dropped by something like 10,000 fold. Nothing changes by 10,000 fold. It's gotten dirt cheap, but they're not networked together. They're not talking to each other. We're not using it for that kind of purpose. So I do think the technology's there, the information systems are there. All these places I talked about have some internet capability. Maybe we'll use, Elon Musk's Starlink thing or something like that. There's just ways to do it. And in some of these places, you can do it with a fresh start where you're not blocked structurally.
Mm-hmm. It's almost time for us to throw things open for questions, and I hope people will be eager. Please feel free to ask Joe whatever questions you have. But I guess my last question for now is, it's been quite fascinating as an observer watching science play out in a pandemic. I have been accustomed to science working in a certain way, where people are very, very private with their research and their findings, and then they wait a very long time to share them until they finally come out in peer review. Now it's like people are just getting these things out onto preprint servers as fast as they can, and they're even complaining that, I uploaded my preprint this morning and it's not online yet this afternoon. Come on, people, we have lives to save. I'm sort of curious to what's been like for you as a scientist, like how you feel that the process of science has changed. And do you think that that those things are going to stick, or do you think we're kind of go back to the old, slower ways?
No, I think they're going to stick. The BioHub is ahead of the game on this. In 2016, we made a policy said if you work at the BioHub and publish papers, you got to put it on preprint servers.
In 2016,
yeah, well ahead of this game. Mm-hmm. And so we were on that from the beginning. And of course, I'm a huge proponent of open access publishing as well, which is kind of another layer on top of that. But preprints, I think are great because things have to move fast. And the peer review system, while important, moves slow. It still has its place, but in a pandemic, you need to move the information quickly. That puts the onus on the readers, like myself and others and yourself, to be kind of reviewers too. You got to be a reviewer now because someone else hasn't done the job of reviewing it. And so there's more work in reading the papers, but the speed at which things come out, I mean, I don't look at the published journals anymore because I've already seen it all in preprints. Now you can see the evolution from preprint to peer review journal. You can see some of the changes and how they improved it and all that. But the core messages, really important to get out quick. And I think what this taught us is the speed of information transfer can be very fast, and preprints can facilitate that. Is there junk in the preprint server? Sure, there's plenty of junk, but that's why the onus is on you to be a reviewer. So it's more work, but it's fast. It's really fast. And we watch the preprint servers like a hawk now because the good stuff is coming out there.
Yeah. Great. Well, Robert, how do you want to take things next? Do you want to take a pause or go to questions?
Leave it to our host here.
We'll take a brief pause, but this is to do our raffle because we've got 2 books. In fact, I've been corrected. Your latest book is not what I said. It's in fact Life's Edge, right? Let's see, The Search for What It Means to Be Alive. So that's as of March that was published. So we thought we would give away a copy of that book, and then maybe a copy of your former book. That's the one that's about your mother's laugh, right?
Yeah, Your Mother's Laugh. It's about heredity.
So both of those are fascinating, and I think Nick has gone through the people who are online and come up with a random person, hopefully not one of the participants in this conversation. And Nick, do you have a name for us?
Yes, I do. Just wanted to, I've had a chance to go through and randomly drawn a couple of winners. So congratulations to our 2 winners. I'll be contacting you via chat. And we'll of course need to get your mailing address so we can send you the book. If you don't feel like doing that, I may move on to someone further down the list. So be ready for that. So just to announce our winners, we've got Don Lloyd will be winning Life's Edge 2021, and Janine Bloomfield, who's also on, will be winning She Has Her Mother's Laugh. Congratulations to both of you, and I'll be in touch shortly to get your contact info so we can send you that present.
Great, thank you. Congratulations to the 2 winners, and it shows you that it's worth tuning into these Nuxwa events. You may win a free book. So we do have a bunch of questions, and when we were chatting before, Joe mentioned something about people always ask about the origins of COVID. So of course, the first question that came in was, can you speculate about the origins of the SARS-CoV-2 virus? Is that a lab escape, or what is it?
Yeah, well, that's a tough question. That's a zinger, obviously. So, first off the bat, I'll tell you that, obviously we still don't know the truth, and it may be hard to ever find the truth. So let's just say that right up front. But, there's a very nice article written by Edward Holmes recently that just came out, summarizes a lot of the data and evidence. And, and it kind of tracks very well with our own thinking here, that the body of the evidence does not suggest a lab involvement. And there's several points that could go down the list to enumerate about why it does not support. So the easiest explanation is not a lab environment. And I could talk about each of those points if you'd like. But one of the things that I often get from just people on the street that I talk to and so on that ask about this, and Carl, I'd love to hear your opinion on this too, is, well, hey, the virus appeared to start in Wuhan. There was a virology institute in this big city, not super close to where the cluster in the seafood market was, but it was in the city. What's the coincidence, right? Well, I worked on SARS in 2003 too. Almost the same virus, very similar. Didn't have a virology institute, didn't need one. What's the same? Lots of wet markets. And I think that we need to really, consider the zoonotic transfer thing very seriously, because that is the easiest, most direct explanation of the data. And we could talk about other points along this line too, but this is how, we're viewing the data. Will there be revelations that change our opinion? Maybe. And do we know the absolute truth? No. But I do think we would be better served if we could get down to the very bottom of it and understand where exactly it came from.
Yeah, I mean, I'm reporting on this issue, and so I'm sort of watching the debate play out very slowly in fits and starts. There's a little, it's, as journalists, we're at the times we're trying to just focus on what actual evidence there is and what new evidence there emerges. And as you say, like, there's not a lot, and what is emerging is coming out pretty slowly, but you do also have to sort of like you do find yourself having to sort of like evaluate arguments as well. So it's a tricky exercise as a journalist. So when people say, "Oh, what a coincidence that it emerged in Wuhan, where you have this institute," like, Wuhan is like bigger than New York City. I mean, it's like it's
huge.
like yeah. It's so it's not like it's not like a tiny little crossroads with a virology institute and that's it. So. And, and where are you going? I think also, as is the case of SARS, like, where are you going to first become aware of an emerging virus? Maybe in a huge city, which is, SARS became, emerged, came to light in a city, in a very urban area. So, yeah, so that kind of argument, I think it's important to look at critically. But Joe, like, what do you, for you, in terms of evidence that could, the WHO tomorrow apparently is going to make an announcement about their phase 2 of their investigation of the COVID origins. Like, what would your personal preference be for what to look for? Like, what evidence do you think would be important?
Okay, sure. Really simply, one of okay, first of all, to evidence that speaks to our own experience and things. As part of research studies, we grow virus in lab, in dishes, culture dishes, at very safe conditions, by the way, BSL-3 conditions, incredibly safe. Our people are well trained. And when you grow SARS, COVID-19, SARS-CoV-2 in particular, in culture dishes, in cells, not a person, it adopts very characteristic changes in its genome, very characteristic mutations of being in culture. Actually, it's very problematic. It causes problems.
So just to clarify, so it's adapting, kind of evolving to live in a dish.
It's evolving to live in a dish, and actually it undergoes a bit of a deletion. So it's very hard for it to go back. And this deletion is very characteristic of lab-grown things. And it caused problems for researchers early on. And one of the things that we don't see in the earliest of sequences are these characteristic mutations of growing in lab dishes. They're not there. They're just not there. And they appear like right away. I mean, they're extremely rapid to appear. The other thing that others have pointed out, and I'll point out here too, and again, I refer to this very nice paper by Edward Holmes recently on this, was that look at the variants that are out there now. They're aggressive. They have really great mutations, great mutations. They're better mutations for binding and infecting humans through the receptor. Mm-hmm. And very early on, we saw some very quick adaptations in people, like the 614 mutation, and then ultimately the 501 mutation, and the 452 and the 484. Those make the virus more optimal for humans. And so very early in the infections, in the SARS sequences, none of those are there. Nothing is optimal. It does not look like a human optimized sequence at all. In fact, what we can see is a bunch of rapid changes as it went into the human population. So it lacks evidence of being selected for or in any way optimized for humans. If anything, it's not optimized for humans. The first SARS sequences aren't good. They kind of suck. So anyway,
they're becoming optimized for humans, though.
Well, yes. I mean, you have millions and millions of infections and trillions of virus in every person. You're rolling that dice. It's doing the optimization as we speak. But to the point, early on in the pandemic, we saw changes very, very fast. So these are easy changes to make, super easy changes to make. And they weren't made in the earliest sequences, meaning if they had been in people for any length of time prior to that, we should have seen these sequences. And so that's another piece of evidence on top of others that suggests recent zoonotic transfer.
Great, thanks. We had a question from the winner of one of our books, Janine Bloomfield, about, is there any insight into why some people are much more susceptible to getting COVID-19 than others, aside from pre-existing conditions?
Yes, actually, I mean, obviously the whole puzzle isn't worked out, but there are some really great things that we do know now. So Jean-Laurent Casanova at Rockefeller, in a nice study that we were ultimately able to take part in as well, described that in older individuals, some of these individuals have autoantibodies to their type 1 interferons, meaning they have antibodies that basically lower their antivirus shields. And COVID didn't cause this. They were walking around with these prior to this. But they didn't know they had a pre-existing condition. It's not a pre-existing condition like you would think diabetes or one of these things are. Maybe they get a cold more often than other people. But when you get COVID, a serious problem. You're missing your type 1 interferons, you're going to end up in the ICU. And so it was highly correlated with severe outcomes and much worse outcomes. So I think that is one highlight, that there's rare things in the population that we didn't really know about or even appreciate. You layer a pandemic over the population, and now this weak signal becomes a blaring noise, and you wouldn't even have known it was even in your population unless you look, because it's rare, but it's not rare when you infect millions and millions of people.
Yeah, we've been reporting on some really interesting genome-wide association studies. This is another example of the kind of open science that Joe was talking about, where teams around the world are looking at these different cohorts of people with COVID, 1,000 here, 1,000 there, all over the world, and looking to see if there are any genetic factors that are associated with either getting COVID or getting severe COVID. And they're finding a few things that really stand out. Some of them are, genes that are very highly expressed in the lung. I have to say, as someone who has written a lot about evolution, my personal favorites are two genes or two little regions of the genome that people, if you inherit the versions of these regions from Neanderthals, that influences your effect. So one of them makes you much greater risk of severe COVID, and one of them actually protects you from severe COVID. Now, why Neanderthal versions of these genes would have, from 60,000 years ago, would have any effect on us today with a modern pandemic is completely fascinating to think about. But it's the effects are loud and bright and strong. So it's really very much there.
Well, I'll add one thing on that. The billion-dollar question here, trillion-dollar question in all this has not been answered at all adequately by anyone that I can tell. And correct me if I'm wrong, Carl, maybe you know more about what's coming out soon. There is nobody that can tell me why any two individuals with the same level of virus, one has symptoms, the other doesn't. Even in the same family, highly related individuals, some people will be completely asymptomatic and shed 10 to the 10th virus per mil. And the person next to them has exactly the same level of virus and they're in the ICU. And this is what drives the pandemic. The fact that you cannot know who's actually got it by symptoms. And so it's not just severe or not, it's like no symptoms. And it's around 30 to 50%, depending on the study. In ours, it was closer to half. And immunologically speaking, I don't know how that happens. How can you be producing a factory load of virus and not feel that somehow? So there's something we're missing here. Yeah. And I don't know what it is, but if we figure this out, it's a big deal.
We had a question from Rick Rohrer. I think we can unmute him. Rick, are you there? You want to ask your question?
Oh, yes, just to ask, in all of this work, is there a role for machine learning? It seems likely that if the virus can only mutate so much before it can no longer attach to its receptor, and we have a number of mutations already defined, can we not predict what the quote unquote final SARS virus will look like?
Yeah. Can we predict the final form? The ultimate boss state. Through not only just machine learning, but genetic selection, and you can make pseudoviruses out of these and you can select them in the lab and see. And in fact, many of the mutations, like the mutation at 484, which is, one of the key ones for vaccine escape, that mutation was in fact predicted by early experiments. And you can see these. What the experiments in machine learnings don't do well is predicting the combination of things. It was like a lot easier to find one amino acid, like 501's bad, 484 is bad. But the combination of 677 with a 452 and exactly this change, that space is huge. And we do less good at predicting the constellation of effects that produce something that's overall better. But here's something that's promising. There's so much sequencing has gone on, and we've seen so many versions of this virus, and there's so many assays now that should be enough data for machine learning algorithms to get a better handle on what maybe the final forms would be. That plus dynamic, molecular dynamic simulation with docking with the receptor and many other techniques should shed additional light where there hasn't been. But, I'll just say also that Mother Nature continues to surprise. Evolution's pretty clever.
Yeah, I actually believe there's some machine learning work that's going on in the UK right now, just trying to deal with this massive problem that you were just describing, Joe. I mean, it's not just a potential idea, but it's actually it's underway now. We'll see if they can make these sorts of predictions. But yeah, I mean, I think that certainly I mean, it has been really the sort of holy grail for years of saying well, if what would this mutation do? What would this combination of mutations do to a virus? And even when you're looking at them in a dish, it's very challenging. And that's ironically, that's kind of what motivated these some scientists to use so-called gain of function research to try to just run experiments to see, well, what does it take to take, say, a bird flu and make it a mammal flu, because you couldn't predict it. But
right.
We're
Very
hearing
important.
all about gain of function now in this new light.
Yeah, right. You have to be careful. So, the way these are done now is what's called pseudovirus. So it's not the real virus, just the coat, the spike, and it's got something else on the inside. So you can run those gain of functions, but you're not using actual COVID, and it can't be COVID. So, you can do those in a safe way now. And actually, I think those genetic selection experiments are the way to do it because it's faster. You can run it, with billions and trillions of molecules faster, and a machine learning algorithm is going to be able to do it because you're limited by the input training data.
Interesting.
Great, thanks. Tom Abadi, I think we can unmute you. You had a question.
Honestly, not a question. I just wanted to spin our thinking forward. to what about the next time? And is there a way to produce a delivery vehicle for a vaccine, stick an antigen, pre-approve the delivery vehicle for safety, and stick an antigen in, which took about 2 months this time, and then gearing up the production was what really took the time in the remarkable response that we just had. Could we save 8 months by creating an insta vaccine? I did some thinking about that, about some work at Stanford. Please take a look. But that's the kind of thing that I think the community has to come up with. This is just one idea. If we're not ready to do something differently, fixing the fax machines, which is necessary, totally, is not going to cut the mustard next time. We're going to have the same disaster that we had.
Yeah, I fully agree. And I think that in particular, mRNA vaccines have that programmable nature that you say, that the formulations and delivery vehicles and stuff can be the same. And many modifications of the RNA that keep it stable are the same, but the coding sequences are different. And so we should be able to be much, much faster. And maybe the silver lining of all this is a new era of vaccinology. The mRNA vaccines are just astounding. They're really quite amazing. And if I think about other things in our environment, now I'm thinking, wow, this is a way to go after malaria.
Joe, that's entirely true, because there's so many niche diseases where you cannot mount the effort into like how 250,000 people have chikungunya disease.
Yeah,
chikungunya. The bodies contort, So yes, we definitely need to think about what's the next level of vaccinology delivery to correspond with the incredible genomics that we're doing.
That's right.
Joe, just to follow up with that, I understand what you're saying in theory. I guess this is another question about theory versus practice. In practice right now, for the most part, mRNA vaccines are a luxury of wealthy countries. For the most part, they are being used in the United States, and Europe is just, locked up 1.8 billion doses. But like if you're talking about using mRNA for malaria, you're talking about a billion vaccinating a billion people in Africa. Like,
yep.
How in terms of manufacturing and distribution, how are mRNA vaccines really going to work for global health?
Yeah. So first of all, one of the things that COVID is giving us is amazing production capacity. Pfizer scaling to billion plus doses a year or more, and that's just one facility. That kind of production capability drives down costs. So COVID has made these things actually affordable, whereas pre-COVID you would have never have even approached this idea. Just way too expensive. So production costs, production techniques, delivery mechanisms, all those are now being worked out in COVID. Basically, COVID is paying for the use of these vaccines in global health in the future by ironing out and creating the production scale and systems to produce them. And it's not like we haven't tried in malaria. The history of vaccinology malaria is one of ruin, with billions of dollars spent already with no operational impact. Like, it's been Teflon. The GSK vaccine has some limited efficacy, but requires multiple boosters for a long time. And you still only achieve about a 30% protection. So we could do much, much better on many of these diseases. And if it lowers the cost for something like malaria, which is already not niche, it's expensive. What about Chagas disease? What about chikungunya, like the question asked? What about dengue? There's just a lot of stuff that is a burden on humanity that now becomes a target because we have economy of scale.
Yeah, and it was just a few weeks ago, I think that I believe it was Walter Reed researchers, they actually tested an mRNA vaccine for malaria in animals and got sterilizing immunity. So this is not purely hypothetical. This could
No,
work.
I think it's a new era. It's a time to go after diseases anew with a refreshed vigor that we haven't had in 50 years.
We had a question from Jim Schumann. Are you still online and want to answer that? Can you unmuted, I think.
Yep, I am. So first off, thank you, NCSWA, Joe and Carl, for the work that you're doing and continue to do, and the opportunity to share that with this audience. Question for you: aside from fixing the fax machine, what's the biggest learning from the past 18 months that you will apply moving forward?
Wow, I mean, so many learnings. I'd be interested in hearing, Carl, your answer to this. It's complex. Carl, why don't you go first?
Sure. Well, I think as journalists, I think it's really hard to figure out the timing of how science works. So on the one hand, I think we were all kind of stunned by how fast the vaccine research went. I don't think it was hard to really reckon with that. On the other hand, I recall, I was very early on, reporting a lot on very exciting, promising, very basic research findings on treatments for COVID. Like all these people are getting sick. How can we help them? And there was a lot of work saying like, oh, maybe we could repurpose this drug or that drug. And there was some very sophisticated work early on showing some promise for things, but I think maybe I personally feel like, and maybe other journalists feel like we didn't really reckon with just how long it takes to go from something that's working on some cells in a dish to animals, to people, and so on and so forth, and just the logistics of getting clinical trials to work and so on. The fact is, right now, all we have, like in terms of an authorized drug for an antiviral for COVID is remdesivir, which is not really very good at all. If you talk to a lot of experts, it's not great. We could do a lot better, and dexamethasone is very good, but the reason that we got dexamethasone is that people in the UK had the patience and the foresight to set up really good, big randomized clinical trials and wait for them to work. And I don't think it really was quite a lesson to me that, that without that kind of rigor, you're not going to find really good drugs. And in the United States, we haven't really found them yet. We might in the future, but that's been a really sobering experience for me.
Yeah, I would agree with that. The antivirals, I had early on, prior to the vaccine developments, if you'd asked me, I would have said, well, I'll probably put my money on a small molecule, because vaccines are hard. They take a long time. Well, antivirals are hard too.
I had people experts predicting like, oh yeah, by July and August, we'll have something. July and August 2020. There's a lot of confidence and it just didn't pan out.
Nope. It's been tough. The antivirals are tough, especially against RNA viruses. And, there's a history of those being tough. So we maybe shouldn't have been surprised. And there wasn't, when you looked at all the, FDA approved compounds and stuff, and we and others have done that, just not a lot in there. It's not a lot that works at all. And so our compendium of drugs that we have already approved, there wasn't anything, it's been picked over clean. So that was disappointing. That was a big learning. I think for me, one of the big learnings over the last year and a half, and something we learned early on in this, is there's a price to pay for inaction. There was a constant drumbeat in certain sectors of just wait. Like, let's wait, see how it goes. Let's not do anything right now. Let's wait. And, there's a price for waiting. And sometimes you have to act quickly, and sometimes the decision is wrong when you look back and it wasn't the right decision to make at the time. But there's a real price to pay for not making a decision or doing anything. And so that's a powerful lesson for us.
Great. Well, our time is unfortunately up. We appreciate Dr. DeRisi's being willing to come here for an hour of his time, and Carl for spending the time quizzing him on what's new with the pandemic and what we can look forward to in the future. And I appreciate all of the people who signed up and tuned in and the great questions. So anyway, thank you very much to our two panelists, and I hope to see more of you back in our next event in the next few months. So thank you very much, and good night, everybody.
Thanks
Thanks a lot.
for having us here. It's been great.
Take care.